Hi, everyone. I am Dr. Lauren Kriz. I'm a pelvic floor physical therapist and owner of Cultivate Pelvic Health. I have my partner on here with me, Dr. Summer Samhori. She is also a pelvic floor physical therapist and owner of Pelvic Vitality PT. And we are here today to interview the wonderful, marvelous Dr. Carrion. So, hi. A quick little introduction. Dr. Carrion is a nationally recognized urologist and professor and chairman of the Department of Urology at the University of South Florida Morsani College of Medicine. He specializes in sexual medicine and men's health, which is why we're here, offering expert care with a compassionate, patient-centered approach. So thank you for joining us.
The honor is mine. I am very excited and thank you for the invitation.
Thank you. So just kind of throwing it out there right away. So with pelvic floor therapy, I think a lot of times when you kind of talk about pelvic floor physical therapy or pelvic floor health in general, people automatically think about women, which is
Yes.
great, but
Yeah.
men have pelvic floors as well, correct? We all do.
Absolutely. Absolutely.
Excellent. So with that, first, let me take a quick step back and say we are here to talk about men's pelvic health, but tell us a little bit about you. What inspired you to specialize in urology, and what drew you towards sexual medicine specifically?
It's going to be such a biased answer because those who don't know my background in the state of Florida, urologically, everyone knows me. And in fact, we have our Florida Urologic Society annual meeting coming up. When I'm introduced, I'm actually introduced as Carrion's son.
Right.
So those in the know for sex med, one of the first penile implants to hit the market was 1972, University of Miami, and it was named small carrion. That's not an adjective, by the way. That's another urologist, Michael Small. Michael Small and Hernan Carrion, not this Carrion. I wish it was this Carrion. They came out with the implant, one of the first in 1972. So you could almost say I was born into the field. So it's biased, even though mentally I go to med school, I'm thinking, no, I'm going to do whatever I want. I end up doing urology. Then in urology, I'm like, no, I'm going to do whatever I want. I end up doing what dad did for 40 years. Now, granted, he was one of the pioneers because there was no formal sex med. There wasn't even a fellowship, but now it's very well formed. So, long story short, yes, I was born into it. And little cheat, my son is a second year med student at Wake Forest and already doing urology research. So there may be a three-peat.
So, like, if you're a man in your genealogy, do you have to just go into urology at this point? Like, you started this trend, right?
It's
Your
it's
grandson's
now
gonna have to do it too.
it's now on autopilot.
Yes. So, tell us what men's pelvic health means to you.
Perfect. It's twofold because I was trained as a general urologist first. And so we had reconstructive urology. We had people, I didn't have much sexual health education during my training, but Odorica's, uh, George Lockhart, the former chair, these people were experts on that pelvic floor, but in a general urology setting. And now me in sex health has a little more finite. So what does a urologist think of a pelvic floor? We're looking on, if I'm allowed to use the word anterior scope. So for layman terms, the front part of the pelvic floor. We're thinking things around the bladder neck, the base of the penis. That's where a urologist is honing in to our definition of pelvic floor health, even though we know pelvic floor, speaking the two experts that truly embrace pelvic floor, is I call it the soup bowl. It's an entire soup bowl. So it's got a front, it's got a back, it's got a left, it's got a right. It's got females, like you said, it's got males. And so for me now, in my tenure, since I'm the old man, it's really base of the penis, and I'm looking at sexual health, I'm looking at erectile health, I'm looking at orgasmic ejaculatory health. That's my men's set. Now, keep in mind, even though it's a men's health sexual medicine, It's a huge misnomer, and I'm going to say this before I get hate mail from all my female colleagues and patients. Sexual health is women's and men's. So we're doing a lot with orgasmic health, vaginal health, and really polishing that sexual cycle as well.
Ooh, tell me more about what you're doing with
I'll
orgasmic
pause
health.
there.
Oh, sorry. Yes, orgasmic health. Go into that for a second. What are you doing for that?
So orgasmic function for my men and women, let's start males first. It's it's redefining what they think is, because many of them say, "Oh my goodness, Carrion, help me with my orgasms." And I'm like, "All right, what's happening?" Well, when I finally feel it, I don't squirt any liquid in a layman terms testimonial.
Right.
Well, sir, you are having first orgasms every time. You're just not ejaculating. So on my men, and I'll call a spade what it is. My men typically need more education, not my women, not my females, but my men do. And they're actually floored when I say, hey, orgasms and orgasmic function, totally different than ejaculations and ejaculatory functions. That's why orgasmic dysfunction is not the same as EJD, ejaculatory dysfunction. And so we redefine things, but they are directly dependent on pelvic floor. Pelvic floor directly plays the lead role in orgasmic, let's say orgasmic ejaculatory function, and let's put a small connection to both of them so I don't separate too much.
Okay.
That pelvic floor, I say in layman terms, hums during an orgasm. You want ejaculatory, you want every dropout? Well, you need that humming to be well coordinated and optimal. So yes, it plays a direct role. Now, on the women's side, yes, it gets a little trickier. It gets a little cloudier, and the literature isn't very clear to guide providers. But I know for a and I'm preaching to the choir here, pelvic floor health for FSD, especially on that pelvic floor focus, is huge, 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 especially in that orgasmic function threshold. I'll pause there.
I think Tasha told you that I've been doing a series of interviews with a variety of people. It's funny you say it hums. We had another provider talk about like an orchestra.
Yeah,
Of,
perfect.
right? I know. I love all the kind of descriptions of it. Summer, I know I've been kind of jumping in. Is there anything that you want to jump in and with?
Just curious how you feel about retrograde ejaculation and pelvic floor function.
I think that's also huge. Now, retrograde, I think the tricky part of retrograde or an ejaculation, if you could find let's say I start Flomax on a patient. Well, that's going to be lower hanging fruit. Can I stop it? I stopped a guy today, right? He was like, man, I'm peeing better. And I really don't like that. Every other ejaculate is almost nothing. And when I do ejaculate, it's like barely a drop. So I'm like, hey, we'll stop the pill. How were you before the Flomax? Man, I was doing great, man. I was keeping my partner very, very satisfied. So if you find a cause that's low hanging fruit, I'll just cheat my way to the easy solution. But I had a patient today, because so many are on the internet now. He had ejaculatory dysfunction, young guy, of course, younger, typically have EJD complaints coming to the clinic. And he had already started his own version of pelvic floor exercises, of course, almighty YouTube on top of that internet. And so he was telling me, hey, Carrion, because I told him, if you're still bothered and he's already improved on his own, I have to send you to real PT people, real experts, because you can get only so much off that app, internet, YouTube video. Typically, I'm a big fan of in-person professionals. So if you want to take it one step up, do it. He was a little embarrassed, and that's probably another question. How do you overcome some of these hurdles? He's a young guy of Middle Eastern descent, and he's like, man, but his first question to me, if you send me to someone, is it a male? And I go, no, actually, and I could be naive. I say most of the therapists I know are actually female gender. I'm sure there's males, but they're female gendered. And I go, but sir, you want someone who's good. So he left today, fresh, earlier today, saying, okay, put the order in, but let me think about it. So I am a huge fan. And to answer Summer's question, they play a direct role. I think there are certain things that are not direct lines. This is a direct line. And so, yes, it optimizes ejaculatory emission and it optimizes the feeling and intensity of the orgasmic reaction. Two separate things, and they both help. That one single health parameter helps with both functions.
Thank you.
With the patients that you see, especially for sexual medicine, what are some of the most common diagnoses that you'll receive?
So that's a great question. So we just had our fellows start. They do 1 year clinical fellowship. And I go through my little intro. ED is almost like the poster child, right? My penis does not get erect enough, doesn't stay erect enough, doesn't get erect from the beginning. That's number one. Second, believe it or not, in a pure men's sexual health branch, Peyronie's disease. Oh my God, I don't know what's happening out there, but I sometimes wonder if there's any straight penises left. So that's number two. And then comes some of those innuendos that come all in the same bucket. This will be infertility. Well, we're seeing that that's coming out big time, by the way. It's heavy, it's growing, it's both on the female side and the male side. We only address the men's side of infertility. Pain and inflammation dash infection, because all those lump in. So all my epididymal orchitis, prostatitis, urethritis, all lumped in. Oh my goodness. They're coming and they're as painful to the patient as they are to the providers because we're trying to sort them out. Well, yes, you have burning on ejaculation after 2 weekends ago, kind of unprotected, vibrant sexual weekend. Perfect. We try to hope they screen a classic sexually transmitted infectious picture through the primary circles, but they'll filter into our clinics as well. But epididymitis, absolutely. Prostatitis, absolutely. And that also overlaps chronic pelvic pain and all these other things, especially once you rule out some of the obvious causes. So yes, all that comes into our clinic in domain. But the poster child is ED.
Yes. And what age range do you typically see?
Here's one. I don't know if Summer and Lauren will be floored. Did I see 80-year-olds today? Yes. 70-year-olds? Absolutely. What was the youngest ED patient I saw? 24. So yeah, this little image that Lauren might have that, yeah, Carrion, I'm sure you see a ton of 60s, 70s, 80s. No. Man, they're writing this because one of my clinics are Morsani on campus. For those who don't know Morsani Health Center, that's on USF campus. I have kids ride their skateboard to their appointment to me. So yes, I'm seeing undergrads. I'm seeing high schoolers. Because here's one other thing. There's a myth that only when I'm old, I'm overweight, my cholesterol's up, and all these are important. I developed diabetes, I have high blood pressure, and I didn't have this when I was 20. All that is fair. That's our classic understanding. But here's what they don't understand. If I abuse drugs, I abuse steroids, I injured my penis, right? I'm hanging, and these are just layman terms, snips to ease the atmosphere when they finally come. If you're hanging from a chandelier and you're jumping on your partner and you're injuring it, you're bruising it. Well, guess what? You're in my clinic and you're 17. True stories. So you don't have to do much to injure the penis and it doesn't function the same anymore.
Right. I'll even say, I've had patients, young men, who I've had to encourage them to stop ejaculating like 15 times a day or stop masturbating 15 times a day, right? To
oh my.
Yes, overuse, right? You can overuse things. So, how about once every other day? And they're like, wow, I feel better. Yes, you do.
You just touched on another thing. There's a lot more, I call it solo practitioners, both men and women. There's a lot more. And Sexual Medicine Society promotes self-love, love yourself, you can please yourself, that's all fine.
Yes.
But the 10 a day by yourself, that's
Right.
not healthy.
We've also found the over squatters, the deep squatters, the exercisers lifting heavy weights,
100%.
damage the
100%.
dorsal nerve of the penis. I mean, just, do you see that a lot as well?
Absolutely. Absolutely. Now, add that, let's call that occupational because we do have these gym rats that have to squat 800 pounds for some reason. Fine. But guess what? Let's throw the horse rider. Let's throw the MMA fighter. All these people, truck drivers, how about cyclists, avid cyclists that haven't done the research yet or played with the seats yet? You have to really fine tune. That pelvic floor is fragile.
Right.
What kind of myths or misconceptions do you see around pelvic health?
Oh, all the time. You actually nailed it in the beginning. So the guy I just told today about seeing you guys physically, the first thing he said was, I went online and stuff, but it's really for like pregnant women. That's a huge misconception. And I told him, no, sir, you have a pelvis. And I go, it's popular on our females going through pregnancy, after pregnancy, all that is fair. But everyone has a pelvis. It's a bowl and blah, 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 blah. And I tell them it's actually not even urology. Urology, colorectal, GYN. It really involves, there was a sage professor when I did my fellowship at University of California who said the pelvis in the future, 50 to 100 years from now, is one organ and should be one specialty moving forward. And so that I thought now, years later, because I'm old, and I truly believe, because we're disconnected, right?
Right.
I need more of you two. You guys need more of me, and we're separate. And yes, we have some good traffic, but not optimal still. And yet, with gyne and colorectal, that's even more branches of disconnect.
Right.
So yes.
Okay.
Carrion, do you find that prostatitis is a overused kind of garbage pail term that urologists will just keep giving antibiotics for unnecessarily?
Urologists putting false labels on patients? What, are you kidding me? We do that all the time. It is an absolute default. We don't know what's happening. It's probably prostatitis. The only way to truly diagnose prostatitis is you've done a prostate biopsy and it comes back with inflammatory cell changes. Histologically, that's proof. How many people do that? Who does? You only do that when you're screening for prostate cancer. So knowing that's the only way to prove it, I would say probably, it's impossible to give a number, but let's say a significant proportion of patients labeled with the prostatitis is summer agreed false diagnosis.
We find that a lot of times they get diagnosed with prostatitis over and over again. It really is just pelvic floor dysfunction and tightness and spasms.
But a follow-up to you and Lauren is how many urologists, colorectal, gyne, and then how many those even know what pelvic floor dysfunction is?
Right.
That's the daunting truth.
Right.
Yeah. It's amazing. We'll go and we will provide education or lectures to a variety of different groups, colorectal, GI, urogyne, and so forth. And we roll out the muscles, the pelvic floor muscles and our little models and so forth. And so often everybody's surprised. All of the students, the fellows, the residents are just surprised. They're like, well, I haven't looked at those muscles since my first year of med school. And so it's just
100%. Here's the funny part. My son, having been at MS2, he sent me a picture of the pelvic floor because it's a classic, well-studied anatomic test question, but no one studies the function and the relevance.
Okay. So let's talk about function for a little bit. What types of sexual medicine diagnoses do you find really overlap, or do you feel are a little bit more musculoskeletal or orthopedic in nature?
Well, there's no question. When it comes to three things from my end that we're counseling pelvic floor muscular health, emissions during ejaculatory function, and ready for this? We didn't mention this yet, but we see this all the time, stress incontinence. Because I'm in the survivorship clinic, we're seeing a ton of patients that had a radical prostatectomy is a classic one, but don't ignore cryoablation, hormonal ablation as it shrinks artificially. All the radiotherapists, I don't care what radiation oncologist you talk to, whether it's high dose therapy, external beam, conformal, proton beam, or their new fancy conformal external beam, they all also can suffer some stress incontinence or mixed incontinence. And that's where true strengthening of the pelvic floor muscles apply. Now, there's one thing also, so stress incontinence, one new thing we didn't mention, but also one thing that I don't necessarily find attractive, but we do see it and we do try to help, and that's pelvic pain. Pelvic pain that we see in our clinic because no one knows what to do with it. So go to Carrion's clinic with sex med because we don't know what's happening. That whether you believe in trigger point release or inflammatory, and you guys are releasing trigger points, releasing some of the tension, I absolutely believe in it. So that's another bucket kind of related that we see, also a direct link, and we'll see it. Because chronic pelvic pain, if I were to use an umbrella term for it, let's just use chronic pelvic pain. That's real, even though it's multifactorial in different entities sometimes, where true optimization, whether it's myofascial or true striated muscle, it does need help and benefits from it.
So I know you have a question, Summer, but I'm going to, on the chronic pelvic pain real quick. So, we get some of your patients, right? And I think you've referred to both of us for quite a few years now, but besides pelvic floor physical therapy and addressing that muscular component, how else are you addressing chronic pelvic pain with your patients?
So it's multifactorial. We have, you may know Cjo Pericaudal and several others in the state that deal with pain. You can apply different modalities, oral, local, even surgical, and load the boat with other specialists, right? Neurologists, pain specialists. So we have them all on speed dial. I truly, truly use as a last ditch result the addition of opioids and invasive surgical options, like let's say an orchiectomy, where it's kind of pelvic floor, but it's kind of an external appendage, but anything and everything, we can't figure out what's happening and nothing has worked, even denervation. And he still has writhing, compromising pain. So it is multifactorial because we will rely on my pain specialist and neurologist, but I find that the opinions and the approach to managing diffuses quickly because not too many people, that's why I mentioned Cjo Pericaudal. There are a few providers that will say, you know what? I'm going to stick to the genitalia dash pelvic floor because it's hard to separate just pelvic floor from genitalia, especially if it's a urologist like Cjo. So he'll do RFAs, he'll do local blocks, he'll do denervations, we'll strip cords, we'll play with genitofemoral nerves and stuff like that. But there are options that are not classic pelvic floor PT oriented algorithms. So yes, we can stick needles, we can cut, we can medicate. But I tell you, man, I really like to navigate the waters carefully because you don't want to look for trouble. And the worst case scenario is to apply invasive therapy and you didn't help at all.
Do you do Botox injections by any chance?
I have. I'm really shy about it because our algorithms in the urologic sector aren't well developed. Shoot, they're even using Botox for ED. I don't know if you know this. There's intracavernosal injections of Botox and somehow aids in the smooth muscle relaxation to optimize erectile functioning. Few studies, cohorts, that's not to me prime time. So to answer your question, I have. Do I promote myself in offering that? No.
Okay. I have another question for you. So we get a lot of post-prostatectomy patients,
Yes.
and more times than not, they end up with erectile dysfunction.
Yes.
At what point, and we know that generally urologists or oncologists will prescribe 5 milligrams of Cialis daily post-prostatectomy just to kind of keep the organ alive. At what point, after we've done pelvic therapy, let's say for 3 months or 6 months, at what point do you think it's appropriate timing for you to intervene for the erectile function, where we no longer feel that muscle function is the issue?
I think, and this is where I say we are not joined close enough. We love you guys love us back, and yet we still have a distance. And the reason is a true survivorship provider. I used to have my clinic in Moffitt. You know when I would see them? When it was done correctly, as soon as the Foley came out. Why?
Mm.
Because you guys are working your magic. They think, an oncologist thinks, oh, yeah, I put them on daily Cialis 5s. That means nothing. Let me give you a little penile hemodynamics layman terms. The penis is like a pool pump, like a pool. I don't know if I'm sure you two love going to the pool and maybe have pool access in the back of your homes or condos. That pool pump has to be on intermittently every day. It's not like, oh my God, next week I'm finally going to get in the pool, so I'll turn on the pool the pump an hour before. No. So I tell my patients, you need that penis to be tumesced several times a week. So you mentioned 90 days or 3 months. Imagine me saying on a human phallus that gets erect multiple times on a 24-hour cycle, all normal phalluses will have varying degrees of tumescence in a 24-hour cycle. All 100%. I don't care if you're single, you're in a dedicated relationship, quote unquote sexually active or not, it's getting erect. It's getting erect even when you sleep. But if you get a radical prostatectomy, it's not erect. And it's not erect for weeks, months, even years. So when you say, when should I intervene? You should be getting erect. So let's say I'm getting a prostatectomy. I go to Moffitt, I get my prostatectomy. You know I'm cheating the system. And sure, you could still throw my little candy of Cialis. Meaningless. I need a vacuum device, or I need to inject the penis to get at least one hemodynamic erection a week. That would be true survivorship.
And would a penile pump be considered a hemodynamic erection?
A vacuum device, because the pump could be inferred a penile implant. So a vacuum device, fair, very fair. It's not as oxygenated, but it is spreading fresh blood, and then it stays a little stagnant, but so be it. It's not doing that at all now. And by the way, so you know, incidence of new onset Peyronie's, penile shortening, and penile fibrosis, all over the place, because we're doing one thing that my onc colleagues don't do. We penile Doppler like there's no tomorrow. We do maybe 30 a week. So we're seeing the scar firsthand. And they never had scar before the prostatectomy. And you know what the first thing they say? Carrion, did they do something to my penis when they took out my prostate? No. What's happened, sir, is your penis has been idle for 4 months since the prostatectomy. That pool, and this is real layman term explanations, that pool has algae, dirt, and it's terrible. The pump has been off.
Good analogy.
Sorry, my dog was barking, so I muted myself. When we have the opportunity to work with these patients and they have these concerns, should we recommend that they go to your type of clinic, or should they start back with their surgeon first? You know, how does that referral work? What would you recommend?
That's an unfortunate clause that affects many, oh my goodness, many. So even Moffitt, my colleagues, even Trisha Patel, my partner, they all believe it. And every radiation, anybody who's the prostate cancer therapist, they believe in their modality, and I respect that. They believe they're doing the best to spare nerves, make them continent, optimize their outcomes because they're good. That's all fine. We're not going to touch that. Fine. But the problem is they believe rehab is, well, you know what? We're going to write that Cialis 5s. That's a common one, by the way. I would absolutely tell the patient, demand from your urologist, I want more help. I shouldn't be idle for months before we pray to the gods and say, hopefully something came back. It's okay to be injecting or using a vacuum and then it comes back in 3 months. Perfect. But you don't want it the other way around, where I waited 3 months and now nothing's happened, and another 3 months, another year. So I see a couple patients in that 1 to 4 years after prostatectomy, nothing's helped. And then when we Doppler them, and then when we pull them, and they're very, very upset. And many of them, because we will inject and cause artificial tumescence in clinic. And I'm like, wow, look at this 40-degree curve to the left. They're like, it never curved. I'm like, well, no, the way sediment and I call it dirt, the way dirt, sediment, and fibrosis sets in, sir, now it does pull to one side. They're exceptionally upset. And there, of course, no one's told them any of this. No one.
Mhm.
So yes, you can optimize it. We now have a nice, better funnel to high volume centers like Moffitt. They hired Marilyn Nicholson, so she's starting the survivorship and being more aggressive than just prescribe a pill. And that's another one important to make sure we're streamlined with pelvic floor specialists like you two as well. So they just hired Marilyn, their first general urologist in the group.
Oh,
And
nice.
she's amazing.
Good
So
to
we have
know.
about 4 minutes left. So with that time, is there anything that we haven't touched on that you would really like to make sure your audience understands, hears, walks away with?
Well, I would highlight what you two offer. People still today, when I tell them you have to do pelvic floor exercise, you have to optimize pelvic health, you're leaking, it's embarrassing, it's totally affected your life. You don't want to go out in public. It is such a worse than ED is stress incontinence. And I tell them you have to do these exercises. The first thing they say is, Carrion, you're just like dumping me to something that probably doesn't even work. No, absolutely not. And I'm preaching to the car with you too, but I think it's good public awareness. You literally can achieve miraculous, noticeable results optimizing pelvic floor on the worst of the worst, which is stress incontinence, and optimize all these other entities we talked about, including erectile dysfunction. And that's where I think the public needs to know. It sounds so simple, exercises or special methods to optimize this area we call the pelvic floor, but it's worth its weight in gold. And here's the last keyword. It's natural. If you were to use a spin, and I'll call myself out, MDs that know how to prescribe a pill and surgeons that know how to cut, this is the one of the rare natural modalities that should be endorsed by everyone and actually works. That's my final message.
Thank you.
Thank you so much. I appreciate it.
Thank you, girls.
We appreciate your time.
Yes.
Thank you.
Thank you.